Amanda Vest. I'm a heart failure and transplant cardiologist, and I've recently had the pleasure of chairing a AHA scientific statement regarding malnutrition and cachexia in the acute care cardiovascular setting.
My name is Carlos Alviar. I'm a critical care cardiologist from NYU, and I have the pleasure of working with Dr. Vest as the co-chair and vice chair of this statement.
And the reason we felt strongly about doing this statement is because that we know malnutrition is so prevalent in our cardiac inpatients, and there's a lot of information out there, a little bit of confusion maybe at times about diagnosis, and some evolving evidence about how we can help our patients who may be at risk of or experiencing malnutrition and cachexia.
So among those lines, we assemble an interdisciplinary group of specialists, including physicians, dietitians, nurse practitioners, and amongst cardiologists who have expertise in different areas, geriatric cardiology, interventional cardiology, heart failure, and cardiac critical care, to really put together this statement in a way that was going to provide the continuum of the patient that arrives to our hospitals with acute cardiovascular concerns that have issues with nutrition. We look at, for example, the definition of cachexia, malnutrition, sarcopenia, and how they overlap sometimes in a common pathophysiological pathway. Understanding the demographics of this, the epidemiology of this, we then move into talking about specific conditions like heart failure that has a robust body of evidence, then moving into the cardiac ICU with cardiogenic shock, cardiac arrest, and then peri-procedural in terms of cardiac surgery, nutrition, and everything that has to do with procedures that we do in the cath lab and the EP laboratory. Then talking about transitioning this patient from the acute care setting to a more stable hospitalization and discharge with the strategies to decrease the readmission rates. An important part of our paper is to highlight the role of the dietitian in the interdisciplinary team in the cardiovascular patient management. Then we finalize opening those questions that we need to answer through high quality research to provide the best care and nutrition to the patients with acute cardiovascular disease.
Exactly. Well, when you see the paper, you'll see that there are some key takeaways. We have a table of the top 10 takeaways. We thought we'd share with you very briefly a few of those items. So one is around assessment of malnutrition. And in the paper, we go into some detail about the validation of various risk scores that have been used, as well as the current established criteria for diagnosis of malnutrition. Again, very important to have our dietitians involved in that. We have some important takeaways from the critical care setting.
Yes, in the cardiac ICU, we mentioned how important it is to avoid underfeeding to our patients who come with acute cardiovascular conditions. We make some emphasis on how to strategically try to start early enteral nutrition, including patients with cardiogenic shock with some specific exceptions, and also talking about the discussion that has been taking place in the randomized trials and some controversies about the amount of protein that need to be given at a particular time during the continuum of patients.
Exactly. The other thing that we really emphasize in this statement is to take a look at our processes of care around NPO orders. A lot of our cardiovascular inpatients spend significant proportions of their time in the hospital without food, and we have a couple of recent studies as summarized in the paper that show that that may not actually be necessary to avoid aspiration and other adverse outcomes with procedures. And certainly at my institution, we've really started to roll back on NPO around procedures, so that's something for you to consider as you read the paper.
Absolutely. I think this is going to be one of the most important aspects of understanding why we really need to pay attention to the patient that is in front of us. And just sometimes we leave it on the secondary aspect, but we really have to start thinking about nutrition as a key management strategy for our patients.
Well, thank you for your collaboration on this paper. Our statement is very much enriched by our co-authors across our multi-specialty team, so a big thank you to them for their participation. And we hope you'll very much enjoy reading the statement when it comes out quite shortly.